Hello, good morning to all. I am Dr. SARADA, Professor in the Department of Anaesthesia, Mallarity Medical College for Women. Today, I am going to take lecture on daycare anesthesia, ambulatory anesthesia and non-operating room anesthesia. Get back on your feet in a day with daycare surgeries. So at the end of the session, the learner should be able to describe the principles, steps and techniques involved in daycare anesthesia and anesthesia outside the operating room. What is daycare surgery? Daycare surgery is the modern type of surgery where the patient undergoes surgery in the morning and can be discharged on the same day in less than 24 hours. Anesthesia for daycare surgeries, that is monitored anesthesia care or ambulatory anesthesia, may require administration of general, regional and local anesthesia or monitored anesthesia care supplemented with sedation. The advancements in anesthesia techniques and availability of newer drugs, they have contributed largely to the progress of daycare surgery. The main challenges include the logistics and organization of the daycare setup to make it function efficiently, effectively and safely. These difficulties are accentuated in a resource challenge settings. The pre-anesthetic evaluation is highly essential in determining the sustainability of the patient for daycare anesthesia and surgery, as well as the formulation of various anesthetic plans and strategies. What about historical aspects of daycare anesthesia or daycare surgeries? In 1909, James Nicol, pediatric surgeon, he performed hernia and cleft lip in daycare basis. In 1919, Ralph Waters, anesthesiologist, provided anesthesia for minor procedures in daycare setup. In 1955, Ferguson did 458 cases of inguinal hernia as daycare surgery. The daycare procedure based teaching hospital was first introduced in 1962, whereas an exclusive ambulatory surgery hospital was first created in 1969. The formal development of ambulatory anesthesia came into an existence with the establishment of the Society for Ambulatory Anesthesia. What is the eligible criteria and prerequisites for daycare surgery or daycare anesthesia? Patient screening and selection is one of the primary important requisites for daycare anesthesia and surgery. So, patients are selected for daycare procedures based on some important guidelines. Patient must be sound to understand the delicate intricacies of daycare procedures. During discharge from hospital, an adult person should accompany the patient with written instructions. Informed and written consent to be taken after explaining the procedure. What are the advantages of daycare procedures? There may be significant reduction in medical costs. There is increased availability of indoor beds and some protection from hospital acquired infections and deep vein thrombosis. Less social disruption to patients and their families and minimal need for inpatient hospital resources. Particularly in children, short separation from parents and family is very beneficial to reduce the separation-induced anxiety problems. Faster recovery and more rapid discharge and better pain relief for outpatients, and less preoperative testing and postoperative medication. So it significantly reduces the medical costs. What are the disadvantages of daycare procedures? Disadvantage of daycare surgery include the need for responsible person to oversee the daycare patient at home for the first 24 to 48 hours. The restriction of daycare surgery to experiences senior staff and little opportunity for junior staff to learn or practice. And extra work for the general practitioners in the post-operative period because patients often ring them for advice and treatment. What is monitored anesthesia care? Monitored anesthesia care is a specific anesthesia service provided by qualified anesthesiologist for a diagnostic or therapeutic procedures. Monitored anesthesia care includes pre-procedural assessment and management of patients' comorbidities and peri-procedural risk. Diagnosis and treatment of clinical problems that occur during the procedure. And support of vital functions inclusive of hemodynamic stability, airway management, and able to handle the procedure-related complications. Psychological support and physical comfort to the patient and improving the operating conditions. What are the procedures doing under monitored anesthesia care? Mainly endoscopic procedures like gastroduodenoscopy, ERCP, and flexible bronchoscopy. And minor surgical procedures performed under local anesthesia or conscious sedation. MRI and CT scan in pediatric patients and uncooperative patients. And eye surgeries mainly for cataract. And cardiac procedures like balloon angioplasty, cardiac catheterization, and ablation of aberrant pathways. And these are the MRI suite which is away from the operation theatre, but one should keep everything ready for any emergencies, especially for pediatric patients and uncooperative patients who have to give some sedation and who have to monitor the patient properly. And this is the endoscopy unit. Mainly the endoscopy procedures mainly they do in lateral position or prone position, especially ERCP. So in these cases, so we have to keep everything, monitoring and everything is most important. Especially in lateral position and prone position, if resuscitation is required, so one should be careful and monitor the patient with the proper equipment. And this is electroconvulsive therapy unit. So we have to give general anesthesia for these patients. So we have to keep everything ready, all equipment to be ready for providing anesthesia, and proper monitoring also required for these patients. The three basic components of monitored anesthesia care are a safe, conscious patient, and measures to allay patient's anxiety, and effective pain control. So, monitoring a patient during monitored anesthesia care are ECG, non-invasive blood pressure, pulse oximetry, capnography, and temperature. Some of the drugs commonly used in monitored anesthesia care are midazolam as a sedative, anxiolytic, and amnesic property is used for conscious sedation. Propofol, because of its rapid onset of action and smooth recovery without any residual sedative or hypnotic effect, is used for procedural sedation by giving intermittent boluses or by titrated doses. By titrated infusions also we can give. And dexmedetomidine is as a sedative, anxiolytic, and mild analgesic property used for procedural sedation. And some analgesics like fentanyl, remifentanil, ketamine, non-steroidal anti-inflammatory drugs like diclofenac and ketorolac are also used. And some local anesthetics commonly used are lignocaine, bupivacaine and ropivacaine. And complications during monitored anesthesia care are airway obstruction, respiratory depression, hypoxemia, aspiration, hypotension, cardiac arrhythmias, and local systemic anesthetic systemic toxicity. What is non-operating room anesthesia? Non-operating room anesthesia is the term used for the anesthesia procedures doing outside the traditional operating room. The commonly used places for these procedures are radiology, cardiac angiography, interventional radiology, CT scan and MRI, and endoscopy units, and dental clinic, burns unit, psychiatric unit for electroconvulsive therapy, and renal unit for lithotripsy, and gynecology unit for in vitro fertilization. What are the aims of non-operating room anesthesia? Guard the patient's safety and welfare. We have to minimize the physical discomfort and pain. We have to control anxiety and minimize psychological trauma and maximize the potential for amnesia. Control the movement to allow safe completion of the procedure. Return the patient to a state in which safe discharge from medical supervision is possible. So what is the equipment required for anesthesia or sedation in a remote location away from the operation theatre? So we have to check each and everything whether it is available in that or not. So remember the acronym SOAP-ME, that is to remember S is for suction, appropriate size suction catheters and functioning suction apparatus should be available. O is for oxygen, reliable oxygen source with a functioning flow meter. At least one spare E-type cylinder should be ready. Oxygen cylinder should be ready. A, airway, size appropriate airway equipment, face mask, nasopharyngeal and oropharyngeal airways, laryngoscope blades, endotracheal tube stillets, bag wall masks are equivalent device. P for pharmacy, basic drugs needed for life support during emergency, epinephrine, atropine, glucose, Niaxin and clomiphene. So emergency drug trolley should be ready. M for monitor, pulse oximeter, NIBP, non-invasive blood pressure, end-tidal carbon dioxide, capnography, temperature and ECG. And some equipment for giving general anesthesia or spinal anesthesia or any other local blocks or monitored anesthesia care like sedation. So we have to keep each and everything to be ready. Anesthesia machine with circuits, ambu bag, defibrillator with paddings, gas scavenging safe electrical outlets, adequate lighting, torch with battery backup, and means of reliable communication to main theatre site. Because once you are having any problem in this source, immediately you have to communicate to the persons available in the main operation theatre, so that you will get some help from them. So this is the anesthesia equipment. So anesthesia machine is very important for performing these procedures. So you have to check each and everything whether it is in the working condition or not. Everything is oxygen backup facility is available or not, and all vaporizers for inhalational anesthesia, and all the soda lime canister, breathing circuits, everything is in working condition or not. You have to keep ready. And these are the circle circuits, closed circuits. And this is the main circuit. It is mainly useful for shifting the patient from the operation theatre to recovery room. And working laryngoscope. This is a Macintosh laryngoscopes with curved blades, different sizes of the blades for different age patients, and it should be in working condition. So adult airways, these airways also in color coded for different age groups. And this is the endotracheal tubes. Different size of the endotracheal tubes should be available according to the age we have to keep ready. So ambu bag is for emergency purpose. So for bag mask ventilation we have to keep ready. And face mask, all sizes of the face mask for different age groups. And suction catheters, also different size suction catheters, and nasal prongs for giving nasal oxygen after giving the sedation to the patient, and spinal needles for giving spinal anesthesia. Different size spinal needles should be available, and IV cannulas according to the size, color code. These are also color code. According to color, gauges will be different. So orange is 14 gauge, ash color is 16 gauge, white 17, and green is 18, pink 20, blue color is 22, and yellow 24. So according to the age of the patient and size of the vein, and according to the type of surgery also, we have to choose the size of the cannula. And this is suction machine. Working suction machine should be available in operation suits. And epidural set. If your patient requires any epidural blocks or epidural anesthesia, so we have to keep everything ready. Epidural set or spinal set, and oxygen mask also should be ready. And monitors. In monitors, this is a multi-parameter monitor is required for for monitoring the patients, especially for ECG and non-invasive blood pressure monitoring, and SpO2, pulse oximeter, and UTCO2. UTCO2 facility also should be there. And defibrillator for emergency purpose, we have to keep ready in each and every operation theatre. So many procedures are carried out in darkened rooms. So example, interventional radiology, endoscopy should be able to visualize the flow meters and to check accurate gas flows. We must be vigilant to detect unexpected events such as cessation of oxygen delivery and endotracheal tube disconnection. So one should be vigilant, and one should be aware of how to tackle these complications. So patients undergoing ERCP, endoscopy, and CT guided biopsies needed lateral or prone position. So these positions are difficult if patient requires routine resuscitation. Some special considerations. Anaphylaxis to iodinated dyes is possible. All the drugs for treatment of anaphylaxis should be available. And radiation exposure. All personnel should be aware of the radiation. And hazards and take precautions. All personnel should be aware of radiation and hazards and take precautions to avoid radiation exposure. So you have to check all the monitors and infusion lines. And some special considerations, you have to look into the matter. What is the choice of anesthesia in daycare surgery? So according to the procedure, we have to choose which type of anesthesia is suitable for these patients. According to the procedure and according to the patient condition also, we have to decide. So in some cases, only monitoring is required. In some cases, we have to give local anesthesia. In some cases, sedation. Sedation we can give to some patients and some procedures. And regional anesthesia is required in some procedures. And intravenous regional block and total intravenous anesthesia in few cases, and general anesthesia also may require for few patients. What is sedation or analgesia? This is less invasive, cost and time saving, and high chances of airway and respiratory depression, and there is a safety in conscious sedation higher than deep sedation. So, titration and adjustment of the dose of the sedative agent requires skill and experience. So, for all these procedures, experienced anesthesiologist may be required. What is total intravenous anesthesia? Intravenous agents are used for hypnosis and analgesia. Airways should be protected if the patient is deeply anesthetized. So one should be careful after giving intravenous anesthesia. So we have to monitor the airway. We have to prevent the airway obstruction. And what are the drugs used in total intravenous anesthesia? Propofol, ketamine, fentanyl, midazolam and dexmedetomidine. So what is the ASA guidelines? American Society of Anesthesiologists guidelines for non-operating room anesthesia patients. Reliable oxygen source including a backup supply. And adequate and reliable working suction. Self-inflating resuscitative bag capable of delivering an inspired oxygen fraction of at least 0.9%. Adequate drugs, supplies and equipment for the planned activity. So all emergency drugs should be ready and all necessary equipment should be ready, and if there is any complications, one should know how to tackle the complications. So adequate basic anesthetic monitoring equipment and sufficient space for equipment should be there, and personnel and transportation also should be there. And immediate suitability of an emergency cart with defibrillator and emergency drugs should be ready. And sufficient electrical outlets, isolated electric power or electric circuits with access to emergency power supply, and reliable two-way communication, observation of all applicable building and safety codes and facility standards, and documentation of anesthesia flow sheet is most important. And post-procedural care includes transport to a standard recovery room with the monitors along with the anesthesiologist, and appropriate post-anesthesia recovery unit. In post-anesthesia recovery unit also, we have to check for whether all monitoring equipment is there or not. We have to attach the monitors immediately after shifting the patient to the post-anesthesia recovery unit. What are the contraindications to daycare procedures? Some surgical procedures involving major fluid shifts and significant blood loss, significant postoperative pain, significant postoperative nausea and vomiting, and serious life-threatening diseases, and some serious life-threatening diseases one should not do the surgery procedures in daycare basis. So we have to be very careful. So we have to choose the patients according to the condition of the patient. And morbid obesity complicated by cardiovascular system and respiratory system symptoms. Myocardial infarction or stroke within past 6 months. And significant obstructive sleep apnea. In these patients also we should not do on daycare basis. And poorly controlled systemic diseases. And acute substance abuse. And extreme premature infants. Less than 60 weeks post-conceptional age, we should not do cases in daycare as a daycare procedure. So discharge criteria. Patient must be awake and oriented to place and time. Should have stable vital signs. Patient should be able to tolerate oral fluids. Pain should be manageable with oral analgesics. So there must be a minimal nausea, vomiting and dizziness. After central neuraxial block, when the patient regains normal sensations, muscle strength and proprioceptive sense and also sympathetic nervous system function must be recovered before discharge. Upon discharge, patient must be given verbal and written instructions and a discharge summary with prescription and a relevant contact numbers for emergencies. So post-anesthetic recovery scoring system. This is a modified Albright scoring. One is consciousness. Score of 2, patient is fully awake and able to answer all questions. Score of 1, patient is drowsy but responds to verbal commands. Score of 0, patient is not responding to verbal commands. So the minimum score of 1 must be achieved before discharge. Respiration. Score of 2, patient is able to breathe deeply and cough. Score of 1, patient exhibits signs of dyspnea or difficulty in breathing. Score of 0, patient is apneic and requires assisted ventilation. So a score of 2 must be achieved before discharge. Circulation. Blood pressure. Score of 2, BP either systolic or minimum arterial pressure reading is plus minus 20 millimeters of mercury of pre-anesthetic level. Score of 1, BP either systolic or mean arterial pressure reading is more than 20 to 35 millimeters of mercury of pre-anesthetic level. Score of 0, blood pressure systolic or minimum arterial pressure reading is more than 35 to 50 millimeters of mercury of pre-anesthetic level. The minimum score of 1 must be maintained for 3 consecutive readings at 15 minutes intervals. Heart rate. A score of 2, heart rate plus 20 beats per minute of pre-anesthetic level. A score of 1, heart rate plus 20 to 35 beats per minute of pre-anesthetic level. A score of 2, SpO2 maintain required parameters on room air. A score of 0, heart rate plus 35 to 50 beats per minute of pre-anesthetic level. The minimum score of 1 or higher must be achieved for 3 consecutive measurements at 15 minutes interval. Oxygen saturation. A score of 1, SpO2 maintain required parameters on supplemental oxygen. A score of 0, SpO2 required parameters cannot be maintained. The minimum score of 1 or more required before discharge. Activity. A score of 2, patient is able to move all 4 extremities on command or motor activity has returned to preoperative status. A score of 1, patient is able to move only 3 extremities. A score of 0, patient is able to move only 2 extremities. A minimum score of 2 must achieve before discharge. So what is the take-home message? So by assessing all these things, all precautions to be taken for the procedures performed outside operation room. An anesthesiologist must be vigilant and capable of managing untoward incidents in the remote setups. So before starting the procedure, so discuss the problems related to a case with surgeon and inform to patient's relatives. So you have to inform the risks related to anesthesia and surgery, and you have to take proper consent, informed and written consent before starting these procedures. Working and involving all the team members to tackle the procedures is a must for smooth running of the outside operation room cases. Trained paramedical staff are always helpful to manage procedures performed outside the operation room. So, patient safety is of utmost importance. So, by carrying these daycare surgeries or operations outside the operation room, one should be very careful in dealing these cases and one should know how to tackle the complications. So by this you will come to know how to manage these cases out of the operation room. Thank you.